Welcome everybody. My name is Michael Hartung, and I am pleased to present Revving Up the Radiology Report, where we are going to discuss some fresh ideas to maximize the impact and clarity of your reporting. I'd like to start with acknowledging my awesome co-authors of this 2020 paper in radiographics, which expands on and complements many of the ideas discussed in this talk. Now, while you might think of a radiology report as starting with the findings, it actually starts with three other important elements that will guide your entire report, and those are history or clinical information, comparison studies, and technique. And while it can be tempting to tab through these columns quickly, there are some very important checklist items to keep in mind. For clinical information, when you're dealing with an acute diagnosis, you need to capture several important data points. What is the clinical question and differential, recent labs, interventions, and surgeries? Often we are provided with such little information that you may have to use your own imagination for the clinical differential. For cancer imaging, you always need to go back to that presentation scan, know how the cancer was diagnosed, the sites of disease, and treatment to date. This information will direct your search pattern and reporting, making them as helpful as possible. The comparison field might seem humble, but it remains essential. Find the first scan where the patient presented with disease. Not only does this teach you, but it will help you to know what recurrence or metastases look like. Reading the most recent impressions will help you to know what your colleagues have been talking about and if there are any issues or concerns that you need to resolve in your report. For patients getting imaging every 2 to 6 months, be careful about long-term stability, as it is a potential trap where a tumor or site of disease might be slowly growing or changing but is reported as stable due to subtle changes from study to study. Pick the oldest reported stable study as a comparison to easily be able to detect subtle changes over time. Also, be sure to include overlapping exams that may shed light on incidental or indeterminate findings, such as L-spine MRIs, when you're reading abdominal pelvic CT. For the technique section, we need to understand what imaging protocol was selected and why. For multiphasic exams, you are starting to strategize your approach to efficiently and accurately read each phase of the study. Example multiphasic abdominal studies include cancer staging, urography, and mesenteric ischemia or GI bleeding for acute abdomen. You will be greeted with over 1,000 images and these kinds of studies, and you'll definitely need a strategy to avoid getting bogged down in your reading. Now we're ready to move on to the findings. The findings require the discipline of following a well thought out search pattern to differentiate normal from abnormal structures and give each item an appropriate description. In the findings, we see something and then we describe it. Identifying and describing the findings requires the least amount of expertise in our reporting, and is something that we'd expect even junior level residents to do reasonably accurately, even if they don't necessarily know what those findings mean. The impression, however, requires much more expertise and is our highest level task as radiologists. It synthesizes and makes sense of the findings. It's like saying, I know what that is, and I know what to do next for the patient's care. The most common pitfall in all of radiology reporting is to fail to do any kind of synthesis and just list the findings in the impression. In other words, there's no true impression, just the findings section essentially repeated in the impression. This keeps our reports in the land of less expertise, and there are many reasons why this might happen. Synthesis is hard work and requires expertise, and we may be out of practice or in a bad habit or reading outside of our comfort zone. Sometimes, when you're reading a study, you need some help or would like to discuss it with somebody else, and many radiologists can find themselves working in isolation and unable to reach out to a colleague for input. When you're stuck and busy, there's a temptation to just move on. There are not set standards required for a completed report. In other words, you can just repeat the findings, sign the report, and move on to the next one. So this must be a new problem, right? Well, not according to the radiologist Dr. Enfield, who about 100 years ago described the makings of a bad radiology report, where the radiologist describes in detail all they see, but does not tell what they think about it. Such a report tells much, yet almost nothing. So this tendency to restate findings and avoid clinical synthesis and application is not necessarily a new problem in radiology and is one that will continue to trouble us. The findings can be thought of as a complete, accurate, radiological description of all abnormalities along with relevant normal observations. The stylistic emphasis in the findings is on short, informative, and descriptive phrases, and a budding differential is emerging that can complement the next step, which is synthesis, putting it all together to form the impression. The impression is the meaning of the findings and seeks to answer the clinical question and provide a diagnosis, differential diagnosis, and recommendations. And of course, now it's time to consider a puzzle analogy. The imaging study is like a puzzle to be solved. Describing the findings is like getting the puzzle pieces out of the box, laying them on the table, flipping them over, and accounting for them all. You might even start putting them in groups or clusters, which is like forming an implied picture or differential. The impression is the act of putting it all together into a meaningful picture that you can readily share with others. So far, we've covered the basic reporting structure and how the findings and impression relate to each other. Now let's talk about reporting clarity. In much of our reporting, we can convey more information with greater clarity using fewer words. In this example, the before findings reflect the typical but often redundant sentence structure in radiology reports, resulting in a fair amount of fluff. The before impression is attempting to convey simple ideas, but remains difficult to wrap your head around and requires translation to apply the information clinically. Much of the phrasing is uncommonly used in normal communication and obscures clinically meaningful information. The revised findings is compact but provides the same information. The revised impression is straightforward and easy to understand and apply clinically. Let's consider another example. This similarly long impression contains awkward sentence structure that is fairly typical in radiology reporting. It can be edited and distilled into a shorter impression that now includes additional helpful information to create a more accurate mental picture of this patient's adrenal mass for the reader. Our report should be memorable, direct, and actionable. Don't shy away from simplicity of language for fear that it might appear unsophisticated, as clear, direct language can be easily translated into action by the ordering provider. It's now time to get practical with a tune-up and some ideas for improving the contents of your reports. I will address the findings and impressions separately and focus on a few high-yield concepts. We can divide our tune-up into stylistic and content areas, and under style for the findings, we will focus on avoiding terms of perception and redundancy. Radiologists tend to overuse terms of perception. It is very natural for us to use them because by nature we are talking about what we see when creating the report. However, terms of perception are largely unnecessary except for stylistic or readability reasons. Our perception is assumed as we read the study, and it risks diluting the meaningful information with linguistic fluff as we ramble on using them. Challenge yourself by counting how many of them you use in your own reports, and you'll likely be as surprised as I was and be motivated to slim things down. The second stylistic area for tune-up is to avoid redundancy. While this also applies to the use of terms of perception, it also commonly revolves around making comparisons, which can really pile on in our reports. I think the major reason for this is that many of us create reports as we are actively reviewing the images and thinking, and that unavoidably will create redundancy. Simplifying the findings in this way does require withholding comment into the dictaphone until you have more to say than just your observation. But I hope you can appreciate the difference this makes for simplicity and clarity. It's hard to believe that these short phrases have just as much information as the longer ones that they've replaced, but it is true. So, when you are making a comparison, more terms does not make merrier. Just pick one and move on. That wraps up style. Now we are ready to move on to content, which will include withholding interpretation for the impression and how to handle incidental findings. Regarding interpretation, we commonly blur the lines between the findings and impression by repeating partial or complete impression statements in both sections. It is natural to begin to process and synthesize the findings while reporting them, but the problem is that this creates unnecessarily long and repetitive reports with an increased risk of internal discrepancies, as changes or revisions need to be made in both the findings and the impression. When correcting a trainee's report, for example, busy attending radiologists often focus on the impression rather than revising the findings, so it's best to keep it clean and avoid double interpretation. However, there is an important exception to this, and that is for incidental findings. We have all experienced the frustration from unnecessary follow-up and apparent confusion about what matters in a radiology study. But we must ask ourselves, why is this happening and what can we do to prevent it? I believe a major part of this falls back on us as radiologists for being non-committal and not providing a clear assessment of something as benign and requiring no further follow-up. And so, buried incidentals often benefit from interpretation to avoid confusion or unnecessary follow-up. While there's nothing terribly wrong with the following examples, the problem is that a non-radiologist will likely not know what to do with them, and they can generate patient anxiety, as many internet searches for incidental findings in radiology studies will mention the possibility of cancer, even though we do not find them suspicious at all. So, if you think something is benign, do everyone a favor and just say so by calling it benign or of no clinical significance. But how can we be 100% sure that an incidental finding is benign? Well, we have a responsibility to make a clear assessment of our studies, including clear recommendations. So we have to decide if something can be let go or if something needs to be done. And while this might feel uncomfortable at first, making an assessment avoids shifting responsibility onto the ordering provider to figure out what to do with an incidental finding, even though they don't have expertise in radiology and are asking for our expert input. The goal of being decisive here is to promote radiological competence for all parties and to help teach other providers about what matters in our studies. As we wrap up our discussion of the findings, let's consider how this advice changes with experience and when it's best to prune radiology reporting language. For those of you training junior residents, you should not necessarily be trying to make reporting clones. Early in training, we should encourage their language and even ramblings to flourish in the findings. Residents should be encouraged to lean into the complexity and challenge and not to oversimplify things. In other words, they will develop their radiology vocabulary through practice. Without this essential step, they will lack the depth of vocabulary to accurately describe complex pathology. Over time, as they progress through training, they can prune their reports and simplify their language while maintaining accuracy and depth, but they cannot get there by starting overly brief. Let's take a moment to talk about how structured reporting impacts the findings section. Structured reports must be thoughtfully designed and implemented to follow a logical and comprehensive search pattern. When creating structured reports, one of the first questions you face is what to do with those blanks. Should you leave them empty, pre-populated with normal text, or have selectable text from a pick list? Can you just say normal, or do you need a full sentence? The best answer will ultimately be a compromise and depend on the complexity of your practice and if you are training residents. Self-reflection is needed when implementing structured reporting. You can ask yourself, am I engaged in the report? Are my neurons firing? Does starting with a normal, essentially signable report create a default bias for my review and decrease my engagement? Our practice is an academic referral center which trains residents and fellows. We adopted a completely blank structured abdominal CT template for three major reasons. First, to avoid default bias and give every patient a blank slate for their report. Second, quite frankly, to avoid the inconvenience that pre-populated normal text would have for our complex patient population. And third, we believe that blank fields are best for trainees as they develop their own reporting skills and language. All right, we are now ready to wrap up the findings section and can summarize the goals of that section as follows. As we describe the findings, we start to build an implied differential diagnosis based on the description and language, but without necessarily stating the diagnoses outright. And for trainees, unless you missed something, you should have the goal that your findings section should not require much editing or correction after staffing. You can then focus your efforts on where it often matters most, crafting a great impression. Now we are ready to tackle the impression. We will look at ways to improve both the style and content of the impression. For style, we will discuss avoiding technical language and leading with the favored diagnosis. Avoiding technical language may seem like a straightforward thing to do, but it can actually be quite challenging. That is because technical language is on your mind as you just wrapped up reporting the findings section. But the impression is a communication to non-radiologists, and they are not trained in technical radiology terms. And spoiler alert, they are not interested in them either. One of the biggest offenders is the use of signal characteristics, such as for MRI and ultrasound, and rambling on about these features leads to the risk of misunderstanding in the impression. For these two examples, we remove the MRI and ultrasound characteristics and clearly state what we are concerned about, including recommendations where appropriate. Something that I have found particularly helpful is to try to state the impression in a similar way that I would when speaking on the phone with an ordering provider or presenting in a multidisciplinary conference. In these settings, I find it easier to cut to the chase and state things as clearly and succinctly as possible, and that is precisely the sort of language that we should be using in our impressions. We would never use the following phrase on the phone, for example, but rather we would clearly state that things are worse to avoid any confusion or ambiguity. This second stylistic tune-up point makes such a huge difference, and that is to lead with the diagnosis. Remember, you've already supported your diagnosis in the findings section, and you don't necessarily have to do it again. Looking at both of these examples, the straightforward diagnoses have a risk of getting lost in the lengthy surrounding details. Instead, cut to the chase and say what you think is going on up front. When you lead with a diagnosis or favored diagnosis, you anchor the impression, which provides a context for the reader in which to understand the relevant associated findings. You're basically saying, here is what we are dealing with or might be dealing with, and then you're filling in the important details that follow. That wraps up style, and now we can move on to content, where we will discuss the importance of avoiding clinically insignificant observations and making clear recommendations. It can be challenging to know what to include in the impression and what to leave in the findings, particularly during training. But I think we have all come across unhelpful shopping list impressions that detail nearly every passing observation that a radiologist makes. In this case, it is easy to overlook the fact that there is an ovarian mass that needs to be worked up as you're lulled to sleep by this rambling list. I think the conflict of what to include and what to omit can be approached in a simple way. If you don't want the ordering provider to think about it or act on it, don't include it in the impression. Remember, they are busy and only interested in actionable findings. Our final area of impression tune-up focuses on recommendations, and this brings together a lot of important concepts. Recommendations are a major way that radiologists take responsibility for a study and advanced patient care. So consider the following. Nobody will have greater insight into the study than you have, and nobody will take more time to interpret the study than you take. So we ultimately have the responsibility to provide a complete evaluation and clear recommendations. There are key questions that can help guide the formation of the recommendations, and what it really boils down to is giving as specific or direct of advice as possible. One might object to this and say that specialists are offended with direct recommendations, and certainly that might be true in some institutions where they prefer just to have the facts. But at the end of the day, they are free to ignore your advice and do what is best within their expertise. And if you follow up on cases or present at tumor boards, you will become much better at giving appropriate advice that aligns with their typical management. On the other hand, not giving clear recommendations carries a much greater risk for harm and confusion. And in general, providers are very appreciative of you helping them to know what are the right next steps. A major benefit to providing clear recommendations is that it helps to circumvent the inherent ambiguity of the terminology that we often apply to convey various degrees of certainty. Radiologists pull in a lot of different phrases to reflect certainty and uncertainty, and the degree of certainty is often misunderstood by the ordering provider and even other radiologists, seemingly selected haphazardly or at random. This capograph from a radiology reporting paper illustrates that radiologists and non-radiologists are not on the same page for this terminology. Anything above 0.7 indicates agreement, and anything below 0.4 indicates disagreement about the meaning of the phrases. And thus, basically the only phrase that we all seem to agree on for the significance is diagnostic of. and everything else had a lower agreement on the scale, even phrases like consistent with, highly suggestive of, most likely, or compatible with. To help overcome this basic misunderstanding, some groups have adopted a certainty scale, which assigns your subjective diagnostic confidence with a percentage range and specified term. It is likely that in many cases we have not really considered the specific probabilities of disease to this degree. Forcing yourself to think through just how certain or uncertain you are about a diagnosis can be a very helpful exercise for radiologists and help us push ourselves to deliver the most information that we can in our reports. Of course, this sort of scale reflects subjective confidence, which can depend on expertise and differ from radiologist to radiologist for the same study. Let's now talk about some strategies for approaching challenging studies. To overcome inertia in your impression, start with a true statement. This is often a broader statement about the nature of the disease process and may just be a disease category. Then you can funnel your impression to specific diagnoses that may be true. This allows you to anchor your report with an accurate statement about the disease category and use that anchor to safely consider specific diseases that may or may not be true. In other words, don't swing for the fences with specifics that may be wrong, but instead provide a solid foundation to consider those specific diagnoses. For example, if the bowel is thickened and inflamed, don't get caught up on the specific cause just yet, but instead lead with diffuse enteritis, evidenced by thickening, mucosal hyperenhancement, and edema, and then you can follow that with specific possible etiologies. Or let's say that the pancreas is abnormal looking, but you're not sure if it's tumor, inflammation, or an infiltrative process. You can start with abnormal appearance of the pancreas and then explain why it looks abnormal, and then provide a differential for that abnormality. The last example is abnormal thickening of the stomach, which is a fine category to start your impression with, and then you can get into specifics, knowing that ultimately the patient will need an endoscopy to sort things out. In summary, kicking off your impression by stating something true will give you some great forward momentum, anchor your differential, and provide a springboard into your recommendations. You can also consider this approach as a 4-step process. It starts with anchoring your impression by stating a favored diagnosis or category of disease. Take a few sentences and summarize the key findings so you create a proper mental picture of the scan for the ordering provider. Next, provide a complete differential diagnosis and how seriously each specific diagnosis should be considered. And finally, we move towards action and resolution by giving helpful recommendations. Let's consider some examples of this approach. In this first case, let's say we see a large liver mass and we're pretty sure that it's malignant. So let's start with that and give a brief explanation of what we are seeing. In this case, we are most concerned about a primary liver tumor. And let's say they only did a portal venous phase study, so we can't definitively come down about hepatocellular carcinoma or cholangiocarcinoma. Well, that makes our recommendations easy enough. They can get an MRI, and if we're still unsure after that, the next step would be biopsy. In this next example, let's say an emergency room patient is presenting with a large bowel obstruction caused by a stricture in the sigmoid colon. That provides a great anchor. And notice how we've given the category of disease and the cause, which is a stricture, but without trying to swing for the fence about the specifics of what that stricture is caused by. This anchor could be explained clearly to the patient, family, and admitting team. Now we create a word picture and explain what we see and why the cause is equivocal. Next, we can give a differential diagnosis for colonic strictures with some additional helpful comments. And finally, we can make some practical recommendations. And so, no matter what happens with the final diagnosis, our first line will remain true because we emphasized true statements about the disease category rather than trying to be correct about all of the granular details up front. This sort of report anchors the patient's care and future treatment and keeps all the teams on the same page as they move forward and reaching a definitive diagnosis. In summary, when considering tough cases, don't start by swinging for the fences and being unnecessarily wrong. Instead, focus on the next right step for the patient and consider how your reporting will impact management and potentially help or hinder the patient's treatment. And remember, We provide great clarity and help by delivering clear and specific recommendations. We'll wrap up the talk by considering our skill and expertise in radiology, as these will greatly impact our reporting and report quality. Something that looms in the shadows for all of us is the threat of a loss of skill and knowledge over time, and even worse to have this occur but not even be aware of it. So the question for us becomes, how can we keep our skills sharp and also improve on them? Hopefully, many of us have had the opportunity to train with good, great, or even epic radiologists. Can you think of anyone in your own training? Did you ever have a chance to ask them how they got to be so good at radiology? Many of these epic radiologists care about the patients a lot, and that caring manifests as one of the most potent expertise developing tools around, and that is follow-up. Follow-up provides endless opportunities for feedback, education, and improvement. A natural curiosity about the outcome of our patients and how our reports impact them provides an endless stream of education, and passing along these teaching points to others creates a rich culture of learning and quality improvement in your own department. So what do I mean by follow-up? Well, our reports result in a variety of clinical actions, and those clinical actions will ultimately lead to patient outcomes. When we follow up our cases and seek feedback, we turn back to our reporting to look for ways to improve the accuracy and contents of our reports as they impact patient care. If you engage in this essential feedback and improvement cycle, you will form a deeper understanding for how our reports impact others, and your reports will inevitably improve over time. This process is also where I personally get the majority of my teaching material from, as it forms a complete picture of the way the clinical story, radiology, and surgery or pathology intersect. Now here are some ideas of when to follow up cases. Many PACS viewers have built-in follow-up tools to facilitate this, but you can also use PHI compliant spreadsheets. Just find a system that works for you. And specifically for trainees, I really recommend that you become diligent about follow-up during training and then perform focused reading or studying based on those cases, as such contextualized learning is very memorable. And of course, don't forget to send your attending a quick note about your extra efforts and what you've learned, as this is sure to impress them and also to build trust. It is important to acknowledge that feedback can often be painful. Nobody wants to find out they are wrong or could have done something better. But remember, you are following up your cases to grow as a professional and to ultimately help patients. So keep that goal in mind and give yourself grace, as you will invariably wrestle with cases that you could have done better on. And finally, when you engage in follow-up, the patient and entire healthcare system essentially becomes your teachers. You will get the glory of finding out when you were right, but also the pain that comes with realizing your assessment was incorrect. Your expertise will expand with connectedness and empathy towards the patient and ordering providers as a result. And finally, let's wrap up with some departing principles to guide your way. Radiology reporting is not like learning a fact. Radiology reporting is not a box that you check during training. Reporting is a continual work in progress that will require your careful attention throughout your career and is the apex of our profession. Finally, strive to create the sort of thoughtful, thorough, and responsible reports that you would want for the care of a close friend, family member, or even yourself. And with that, I thank you for your attention, and I hope that you have found this presentation helpful and inspiring for your own reporting.